Good. Well, good evening, everybody. Welcome. Thanks for joining us tonight. For those of you that don't know me, my name is Michael Potter. I'm one of the hand and upper extremity surgeons here with Valley Ortho. We'll be spending some time tonight talking about some common hand and wrist injuries that we see in the winter season and some potential steps that we can take to prevent them. I'll be happy to take any questions you have at the end. If you have questions as we go along, feel free to submit them through the Q&A, and we'll try and get those answered as we go if we can. So winter is on the way here in the Roaring Fork Valley, and for many of us that means getting ready to get back to some of the snow sports and winter activities that we really love. Unfortunately, it also means that snow and ice can put our active population here in the valley at risk for injury, either on the ski slopes or just with slip and fall. So, like I said, one of the things we're going to talk about tonight is some tips and tricks to avoid these type of injuries. So just a brief outline of the talk tonight. The first thing we're going to cover is some epidemiology, which is basically how common are these injuries, who gets them, who needs to be worried about this. We'll talk about some prevention measures, both environmental factors, things you can do to mitigate risk in the environment around you, as well as some patient factors, some things that you can do to keep your bones strong and healthy, and try and prevent fractures if you do have a fall or an injury this winter. And the last thing is we'll talk about evaluation and treatment when injury does strike, and we'll go through a few case examples from patients that I treated last winter. So in terms of epidemiology, distal radius fractures or wrist fractures are the most common fractures of the upper extremity. About 1 in 6 of all fractures that get seen in the emergency department is going to be a distal radius fracture. There's more than 500,000 of these cases a year in the United States. And basically these injuries come with a bimodal distribution, meaning there are 2 peaks. The first peak is in younger patients, typically associated with higher energy trauma. These are your sports injuries, your ski injuries, motor vehicle crashes, or falls from height. The second peak is in older folks. As we age and our bones get weaker, it takes less trauma to cause a fracture, and so in older patients, sometimes these sorts of fractures come just with a fall from standing height or less of a trauma than we see with some younger patients. Hand fractures are common as well, not as common as wrist fractures, but we still see all varieties, whether those be fractures of the metacarpals like you see here, or fractures of the small bones in the wrist and the carpus, or fractures of any of these bones out in the fingers or the thumb. So annual incidence of these sorts of fractures is 3 to 4 fractures per 1,000 people. So still a fair number of these. Metacarpals are the most commonly fractured, and vast majority of these are treated non-surgically. About 4 out of 5 are treated non-surgically. In terms of ski and snowboard injuries, we see that snowboarders in general are at a greater risk of upper extremity injuries than are skiers. Of all injuries in snowboarders, about 40% involve the upper extremity versus only about 17% of ski injuries. For snowboarders, common injuries include wrist fractures and wrist sprains, those sorts of injuries. As you might imagine, if you're on a snowboard, you've got your hands free and you lose your balance, it's common to put your hands out to catch yourself or protect yourself from hitting the ground, and that's how people injure their wrists. With skiers, the most common skiing injury we see is an injury to a ligament called the UCL, or the ulnar collateral ligament. It's one of the ligaments that stabilizes the thumb, and up to 80% of the injuries that we see in skiers involve the thumb. It actually goes by the acronym, or the eponym, I guess, of skier's thumb. And you can see the mechanism of it there on the right. You can imagine holding a ski pole and having some momentum behind yourself, and either the ski pole stops or you fall, and your body keeps moving and the pole stays put, and that can put a lot of stress on the thumb, pulling it away from the hand and the rest of the fingers, and that can cause injury to the ligament. So with strains or partial thickness tears of the ligament, most of these are treated non-surgically. Full thickness or complete tears of the ligament sometimes require surgical repair. So that's the epidemiology, and so what I want to talk now is a little bit more about prevention. and one of the best ways to avoid breaking a bone is not to fall in the first place. So a lot of this is common sense type of stuff, but I did want to talk through explicitly some tips and tricks for avoiding slips and falls when the weather is snowy and icy. So the first recommendation is simply to dress appropriately for the weather and the conditions. This seems pretty basic, but take the example of, maybe tempting to run out and grab the mail or grab the newspaper in your bathrobe and slippers, but you'll be better off if you have warm clothing and proper footwear in case the ground is slick. Having good grip or good tread on your footwear can prevent you from falling in the first place, and having warm clothing will protect you from the winter environment if something does happen. I'd also consider carrying your cell phone with you when you go outside, potentially even on short trips. That way, if you have a slip or fall and there's nobody immediately around, you can call for help from a family member or a neighbor or EMT or whoever you need. Second recommendation is be cautious and allow for extra time. If you're running errands or just trying to get from point A or point B, give yourself more time than you feel like you'll need so you don't feel rushed. Often it's when you're rushing or hurrying from one place to another that you're not paying as close attention to your footing, and that can lead to falls as well. If surfaces are slick, then it pays to walk deliberately and change the way that you walk as you need to for the conditions. If you take a wider stance, you take shorter, slower steps, you keep your feet flat on the ground, you're less likely to slide or fall than if you're taking a normal full stride. It also can help to keep your arms free, avoid heavy packages and that sort of thing if you can, and that gives you your arms to help with balance if you need them. And the last thing is just to be attentive to the path that you take. It may pay to take a slightly longer path to stay on a plowed sidewalk or to avoid a potentially slick or icy set of stairs, even if it means a slightly longer route to your destination. The last one I wanted to talk about, and this is not one we think about as much, but keeping your vision sharp. Impaired vision can make it harder to get around safely, and so doctors recommend that you get your vision checked on an annual basis. If you need glasses or contact lenses, wear those when you're out in the world. Black ice can be difficult to see, but if you keep your vision sharp and you keep your attention on the path in front of you, you're going to be less likely to fall this winter. So the other piece of prevention has to do with patient factors. Basically, the things that we can do to keep our bones strong and healthy. Despite our best efforts, falls will still happen, but with healthy bones, falls need not always turn into fractures. Starting early in life, one of the best ways to optimize bone health is to make sure that we get enough vitamin D and calcium, either from dietary sources or from our diet plus some sort of a supplement. So milk and dairy products are well-known sources of dietary calcium, but you can see on the right that there's a lot of other options as well, nuts and fruits and vegetables for folks that either don't tolerate dairy or follow a non-dairy type of diet. It's a little bit busy there, but the guidelines for calcium and vitamin D intake are listed for most folks under 70 or most folks under 50. Basically 1,000 milligrams of calcium and 600 units of vitamin D are what is recommended. As we age, that recommended requirement goes up. And for those at risk of fracture or osteoporosis, sometimes as much as 1,200 milligrams of calcium and 1,000 or even 2,000 units of vitamin D are recommended. Something you can discuss with your primary doctor if you have questions. The other piece of fracture prevention in terms of lifestyle factors is exercise. So exercise, particularly exercise against resistance or weight training exercise, is a great way to build and maintain bone density. The other thing to consider is a consultation with a physical therapist. Physical therapists can help you design an exercise program to maintain core strength and can also suggest exercises that will help with balance and help keep you upright to avoid falling in the first place. So we mentioned osteoporosis. What is osteoporosis? Osteoporosis is common, first of all. It's a bone disease that develops when bone mineral density or bone mass declines with age, or when the quality of the structure of the bone changes. This is typically diagnosed with a scan called a DEXA scan. I'll show you a picture of what that scanner looks like later in the talk. But basically, the reason we worry about osteoporosis is it increases the risk of fractures, including what are called fragility fractures. So what is a fragility fracture? A Fragility fracture is a fracture that's sustained from a fall at standing height or lower, or some other low energy mechanism of injury. Most commonly involved areas, or most commonly fractured areas, include the wrist with the distal radius fractures we were talking about earlier, hip fractures, and vertebral compression fractures or other spine fractures. Regardless of what the DEXA scan says, if a patient has a fragility fracture, it's a signal that there should be concern about underlying osteoporosis. In my world, that means wrist fractures. Other facts about osteoporosis. For people over 50, in their lifetime, half of women and a quarter of men will break a bone because of osteoporosis. Osteoporosis is responsible for up to 2 million broken bones a year, but unfortunately, nationwide, we do a really poor job of testing and treating patients with fractures for osteoporosis. It's a silent disease, so there aren't a lot of antecedent symptoms. People don't have pain, they don't necessarily know that they have osteoporosis or they have a problem until they have a fracture. So that's where screening is important. The question is, who should be screened for osteoporosis? So the U.S. Preventative Services Task Force recommends screening for women over 65 or for younger women with risk factors for osteoporosis. The screening method of choice is typically a DEXA scan. You can see this DEXA scanner here, so it's not an enclosed situation like an MRI or a CT scan. It's quick, it's painless. The screening recommendations for men are a little less clear, but I'd consider screening men with risk factors for osteoporosis or men who have a personal history of fragility fractures. You can see on the left risk factors for osteoporosis. A lot of these are reasonably well known. Any sort of personal or family history of fragility fracture, females, advancing age, low body mass index, and some of the medication and lifestyle issues you see there. But it can affect anyone, including otherwise healthy, fit men and women. So why do we worry about this so much? Why prevent or treat it? Well, it's not just that you have a fracture and the fracture heals. Some of these fractures, particularly hip fractures, can have lasting impacts, including permanent pain, loss of function, or limited mobility. When you lose function, you lose your ability to get out and around in the community. That can lead to feelings of isolation and depression. With vertebral compression fractures, you can have loss of spinal height or even deformity, stooped or hunched posture from the fracture. And hip fractures especially are very serious. 20% of seniors who break a hip will die within a year from complications related to the broken bone or the surgery to repair it. And many require long-term nursing care after a fracture, which limits their independence. For me, where I'm primarily seeing wrist fractures and not necessarily hip fractures, this is where it's really important for my patients to get proper advice about screening and treatment for osteoporosis so they don't have a more serious fracture down the road. So the good news about osteoporosis is osteoporosis can be treated. And here at Valley Ortho, we run both a fracture liaison service for patients who've had fragility fractures as well as a general bone health clinic to provide full spectrum care to patients who've had fragility fractures or are at risk of osteoporosis. And the goal of these clinics is to make sure that these patients at risk get properly evaluated and treated. So treatment can include things like vitamins and nutritional supplements, the calcium and vitamin D that we talked about, or others, exercise advice or referral to a physical therapist, lifestyle modifications, fall prevention programs, or even prescription medications. And the prescription medications have come a long way in the last 5 or 10 or 15 years. So the goal of this service is really threefold. It's to reduce the risk of future fractures, it's to slow the progression of osteoporosis in our patients, and ultimately it's to keep our patients active and healthy. The last point I want to touch on, and then we'll move into some case presentations from last winter, is just what should I do if I have a hand or wrist injury? Well, there's always the emergency room, but depending on where or when you get hurt, there may be better options. So I would just suggest that during business hours, it may be worth considering a call directly to Valley Ortho first. We have multiple clinics and multiple locations for evaluation up and down the valley. We just opened a new office on Main Street in Aspen. We have an office in the Mid-Valley in Willits, and we have the office here in Glenwood. All of these offices offer X-ray, splinting, casting, and orthopedic services. This is something where, for patients who have an acute injury, there are often same-day or next-day appointments available, and so this may be a situation where you can make a phone call and go directly to the specialist who's ultimately going to be responsible for your care rather than waiting in an emergency room. The last thing I'd like to cover are just a few case examples of patients that I took care of last winter. We'll look at a low energy wrist fracture and what that looks like. We'll look at a higher energy wrist fracture, and then we'll look lastly at a younger patient who had multiple metacarpal fractures after a ski injury. So this is our first patient. This is an 80-year-old female who went out to a restaurant, had some dinner with friends, and as she was leaving the restaurant, she slipped on a patch of ice and landed on an outstretched left wrist. So if we look, not much to see on the frontal view, but on the side view, you can see that she's got a break in her distal radius, like we talked about earlier. Not a terrible fracture, but a fair bit of angulation through the joint surface. So normally this angle would be something closer to 90 degrees. So what should we do? Well, in this case, she had what's called a closed reduction, where she got a little bit of sedation, and then we were able to manipulate the bones back into a proper position and to hold or secure them in place with a plaster splint or a plaster cast. And so you can see the injury films on the left and the post-reduction films on the right, and on the right you can see that the alignment of that joint surface is improved. And so she went on to heal well and do well in a cast in about 6 weeks' time. So what lessons, or what general lessons can we take away from that case? With lower energy injuries, many of them are non-surgical. They can often be treated in a cast or a brace. And these are the sorts of patients where lower energy mechanism, fragility fracture, that prompts us to really consider the whole patient, the big picture, and think about a referral for osteoporosis evaluation or bone health evaluation to try and mitigate the risk of additional fractures in the future. So the second patient I want to talk about is a little bit different. This is a younger patient with a higher energy injury. So this patient was skiing in a terrain park and went off a jump. He lost his balance on the landing, and he landed on his right side, injuring his right wrist and his right hand. So you can see on the left here a wrist fracture. This is a free fragment of the joint here, and also just a fair bit of angulation or dorsal tilt of the joint like in the previous patient. This patient also has dislocations of multiple joints in the fingers and the thumb. So this is a fairly complicated injury, young patient, incongruity of the joint surface. This is a patient that needs surgery to achieve an optimal functional outcome. So on the right, you can see the wrist films there, and the postoperative wrist films there. And what you can see is that we've got the joint surface nicely lined up again on both the views, and the alignment of the wrist relative to the rest of the forearm is in a really good position. So under the same anesthetic, he also had all of these dislocated joints put back into place. And once these joints are put back into place, they actually usually are quite stable, and so he's able to start moving the fingers right away and moving the wrist within a few days. So this is a patient that lives out of town, but I did get a little bit of informal follow-up on him. Later that spring, he sent me a video of himself on the driving range, swinging hard and doing really well in terms of the wrist and the hand. So like we talked about, low energy fractures, often non-surgical. Higher energy fractures may require surgical treatment to get the best functional result. So the last patient is an 18-year-old, also a skier. He'd been out hitting it hard all day, and he was just kind of cruising down at the end of the day, headed for the vehicle, and just caught an edge and came down and slammed his left hand against the ground. And so he fractured two of his metacarpals, the metacarpal to the long finger and the metacarpal to the ring finger. And you can see a fair bit of angulation of those on the lateral. So I ended up having a conversation with he and his parents about treatment options, surgical and non-surgical treatment. One thing that factored into his decision was he was an avid guitarist, and this was his fretting hand, and so he wanted to make sure that he had the best possible functional outcome. And so after discussion, ultimately he and his parents opted for surgery. The other reason that I picked this particular case is that it is a nice illustration of two different techniques for metacarpal fracture fixation in the same patient. So with the long finger, we had this nice long spiral oblique pattern, and so we were able to get 3 screws across the fracture and get that nicely lined up and secured. With the ring finger, we had a little bit more comminution, or a little bit more of sort of these free broken fragments in the middle. And so in that situation, a better choice is a plate with screws that actually interlock into the plate to get that into a good position and secure it again. And there's a little intraoperative photo of his long finger and his ring finger, and so he's done really well as well. So with hand fractures, there's a lot of options, and ultimately the treatment approach is going to be tailored based on the fracture pattern and the goals of the patient. So thanks very much for your time and attention. I appreciate you coming out to listen. That's all the prepared material I have, and so I'll be happy to take any questions. And I just point out that we've got one more talk coming up in December from Dr. Armstrong on foot pain, and the webinar schedule for 2020 will be coming out soon.
I just figured I was going to ask. Sorry, let's turn off my volume. We did have a couple questions, Dr. Potter,
Sure.
that came through. One of them was just about osteoporosis and fracturing. So this person fractured and they wondered if that's a good time to start osteoporosis medications, or should they wait until after they heal? If you have any recommendations for timing.
That's a great question, don't know the answer to that off the top of my head. I think it depends a lot on the particulars of the medications, but that's where I think it's really an excellent service that we have. Is we've got a couple of providers that work with our group that are really knowledgeable about the ins and outs of osteoporosis treatment, and so for me, it's nice because I have a place where I can send patients knowing that they're going to be well taken care of and knowing that they're going to get to somebody that has the right answers for them.
And then we had a question about fracture. That was great. And yes, that is a great time to start medication too. So if you do have a fracture, just send them on over to the osteoporosis clinic and the fracture prevention program. We had a question about whether physical therapy is generally a good thing to do after a fracture. I know you talked about several different ones, and it probably depends on the type of fracture, but where that plays in.
Yeah, I think that's a great question, and that's something that I'm glad you brought up because I kind of glided over that. But the physical therapy or in the situation with hand and wrist fractures, occupational therapy or hand therapy is a really critical part of the recovery. It's treating the fracture itself is part of the puzzle, but then getting back the motion and the strength in the injured joint or the injured hand is something that therapy really helps a lot with and can really speed recovery.
And we have excellent OTs and PTs too that work really well with.
That's absolutely true.
One last question. It may be something that just applies to people who like to go out and shovel their walks, but if you have any ideas on how to prevent injuries when shoveling or doing, manual labor type work.
Yeah, I mean that's a good question as well. So the first thing I would say is I'm glad you're out there shoveling your walk because it's a great way to make sure that you don't fall in the first place. With the shoveling, I mean a lot of it is sort of a strain or an overuse injury, and I think just do your best and take breaks when you need to, and a little Tylenol or Motrin at the end of the day if you need that. Unfortunately, Mother Nature decides, how much and when the snow comes, and so we don't always get a choice about how we pace our shoveling. But I think you just gotta do your best with that. I don't know if I have any magic pearls.
Great. Well, thank you. And like Dr. Potter mentioned, there's a talk coming up December 1st, and then we'll have our 2022 webinar schedule coming soon. So stay tuned.